John, working at Samsung Medical Center in Korea. It's a great honor for me to introduce one of the greatest scholars in our era. Dr. Jinsoo Chung graduated from Seoul National University, and he received a master degree and PhD degree at the same university. He was the president of Kidney Cancer Research Group in the Korean Urological Oncology Society, and now he is the director of National Cancer Center in Korea. Dr. Chung, please.
Thank you. Thank you, Chairman, for your nice introductions. In this session, I will talk about the role of TKIs in the era of immunotherapy in metastatic renal cell carcinoma. And Dr. Professor Gondo and Dr. Professor Lu said almost of my slide, and I briefly summarize previous presentation and previous talk, and then some comment about the management of the metastatic renal cell carcinoma in this period. It's my disclosures, and first I will talk about the overview of the systemic treatment for the renal cell carcinoma, and second, role of TKI in the era of immunotherapy in metastatic renal cell carcinomas. As you know, there are three classes of the active drugs for the management of advanced and metastatic renal cell carcinoma. First, VEGFR blockings, such as bevacizumab in VEGF monoclonal antibodies, and multi-targeted tyrosine kinase, such as sunitinib, pazopanib, and the recently approved cabozantinib also block the VEGF and the EXL and CMET, and lenvatinib is a dual-acting TKIs blocking FGFR and VEGFR, and temsirolimus and everolimus are the mTOR inhibitors, and finally immuno-oncology drugs, so-called immune checkpoint inhibitors, block the CTLA-4 and PD-1 and PD-L1 pathways, such as these diagrams. This slide summarizes the result of the phase 3 trials until 2016 about the approved first-line targeted agent. Among them, sunitinib and pazopanib are the most widely used drug worldwide. For the survival benefit, only temsirolimus in poor-risk patients showed the survival benefit compared to interferon. This slide summarizes the result of the phase 2-3 trials with the approved second-line targeted agent on metastatic renal cell carcinoma. Recently approved drug, lenvatinib plus everolimus combination and cabozantinib, nivolumab, shows superior efficacy than everolimus in terms of the objective response rate and median progression-free survival, except nivolumab, and even in median overall survivals. Recently, there are several practice-changing first-line trials were published or presented in ASCO-GU and ESMO. For IMDC intermediate and patient, cabozantinib showed superior efficacy than sunitinib in objective response rate with progression-free survival and median overall survivals in these cabozan phase 2 trials. Ipi-nivo combination shown superior efficacy also in intermediate and poor-risk patients with improved overall response rate, especially in complete response rate and mean progression-free survival and overall survival than sunitinib in favorable risk patients. But sunitinib shown superior efficacy than ipi-nivo combinations with improved overall response rate, except for complete response rate with mean progression-free survival and mean overall survival also prolonged by the sunitinib than the ipi-nivo combinations. Professor Gondo stated yesterday, PD-L1 expression was considered as a good prognosis and maybe a predictive factor for these ipi-nivo combinations. Recent published or presented preliminary data of these combination trials show also improved progression-free survival, objective response rate than sunitinib in positive and negative patient also, but PD-L1 positive expression was suggested as a prognostic marker also in these studies, but the response rate or median progression-free survival was somewhat disappointing than we expecting. According to these results, NCCN guidelines recommend pazopanib and sunitinib as a preferred treatment regimen of favorable risk patient. For the poor and intermediate risk patient, ipi-nivo combination and cabozantinib recommend as preferred regimen. For the subsequent treatment, cabozantinib and nivolumab are recommended as preferred regimen, and axitinib and lenvatinib plus everolimus recommend as category 1 recommendation, such as these tables. Similar to NCCN guideline, updated EAU guideline also recommend sunitinib or pazopanib nivo-ipi combination in MDC good and intermediate risk patient. For the second and third line treatment, cabozantinib, nivolumab, and any other VEGF targeted TKIs are recommended according to previous treatment, such as these tables. From now, I will talk about the role of TKIs in the area of immunotherapy in metastatic renal cell carcinoma. First line therapy in metastatic renal cell carcinoma. CABOSUN trial was randomized multicenter trial of the phase 2. It compares the efficacy and safety of the cabozantinib versus sunitinib in previous treatment-naive patient in IMDC, intermediate and poor risk patient. Cabozantinib shows superior efficacy than sunitinib in progression-free survivals, overall survivals in this slide. And according to subgroup analysis, MET expression and bone metastasis suggested as the good prognostic biomarker with these cabozantinib treatments. The incidence of all grade and grade 3-4 adverse events are comparable with the two treatment groups. This slide shows the slide design of CheckMate 214 studies. It compares the nivo-ipi combination with sunitinib, mainly in the IMDC poor and intermediate risk patient. Nivo-ipi combination shows superior efficacy than sunitinib in these intermediate and poor risk patients, especially the incidence of complete response was strong, high in ipi-nivo combination, 9% versus 1%. And overall survival also prolonged with the ipi-nivo combinations than sunitinib in these intermediate poor risk patients. And PD-L1 expression also suggested as the good prognostic and maybe a predictive marker for these ipi-nivo combinations in intermediate and poor risk patients. But in favorable risk patients, sunitinib showed superior objective response rate and progression-free survival, even in the improved trend of improved overall survival than ipi-nivo combinations, such as these tables. There are several differences in the toxicity profile between two treatment ipi-nivo combination and sunitinib's. Ipi-nivo combination shows several immune-related adverse events, such as these tables. So, Ipi-Nivo combination in intermediate and mRCC patient is a current standard, but it also contraindicated in the patient with autoimmune disease. When we consider the use of Nivo-Ipi combination in intermediate and poor risk patient, several factors we consider for the clinical use of these combination therapies. Is it the best combination? There are so many combination therapies are ongoing, and is it better than all TKIs? How about the subsequent treatment? And the cost is the main problem with these combination therapies. And there are some reports about the immune-related adverse event with several fatal cases. This slide summarizes the several ongoing or presented the preliminary data of the TKI with immune-oncology agent combinations. We're still waiting the final result of these data. And for the first-line treatment in intermediate to poor-risk patient, Nivo-Ipi combination shown somewhat higher efficacy than cabozantinib, such as these tables, but it is an indirect comparison of two studies. But in the previous study or on any other combination or IO monotherapy, there are several reports about the treatment-related deaths. Immune-related fatal deaths are sometimes so we concern about these immune-related fatal toxicities. In summary, for the first-line treatment of metastatic renal cell carcinoma, still sunitinib and pazopanib are good options for favorable risk patients, especially in PD-L1 negative patients. Cabozantinib is a reasonable option in intermediate and good risk patients with proven PFS benefit, and it was more effective in c-Met positive and bone met patients. Nivo-Ipi combination is a preferred regimen for the intermediate and poor risk patient with proven overall survival and long-term remissions, and it's shown favorable toxicity profile and more effective in PD-L1 positive patients. But we also consider the frequent immune-related adverse event with this treatment. The IO TKI combination or other combination therapies, the result is so immature. So we will wait the final result of these data. How about the subsequent treatment? Meteo studies was a randomized phase 3 studies to evaluate the efficacy and safety of the cabozantinib versus everolimus in patients with mRCC who progressed on prior TKI therapies. Cabozantinib showed superior efficacy than everolimus in PFS and even in OS, such as these diagrams. And cabozantinib was more effective, especially in the bone metastasis patient. We consider bone metastasis is a poor prognosis for the metastatic renal cell carcinoma. But the toxicity profile or the incidence of the adverse events are somewhat higher in cabozantinib treated group than everolimus. This slide summarizes the recent approved or recent reported TKI and other trials for subsequent treatment after first-line treatment. Lenvatinib plus everolimus combination shown highest overall objective response rate, PFS, overall response rate, but they also show highest dose reduction rate, discontinuation due to adverse event and toxicity. Nivolumab shows a modest progression-free survival, but they show good overall survival and bad probability of other drugs. In conclusion, role of VEGF TKI remains the critical for successful management of metastatic renal cell carcinoma in the first line and subsequent treatment. The combination of sequence of VEGF TKI with novel IO agent prolong the survival of patients with mRCC. And especially combination therapy with immune checkpoint inhibitor and the TKI are evolving and promising. Novel biomarkers such as immunotherapy, CMET, PD-L1 expression may aid the individualization of the therapy. Professor Lu showed this slide. This slide is one of the examples of the biopsy-driven personalized management of the advanced kidney cancers, such as first patient stratified with IMDC criteria, and then PD-L1 expression. And cabozantinib should be considered in the patients with bone metastasis also. Thank you for your attention.
Thank you for your nice and informative lecture. Now I'll open the floor for, yes. Dr. Han, please.
Thank you for the very comprehensive review of the targeted therapy and the immunotherapy. You mentioned, repeatedly mentioned that there's a prognostic implication of a PD-L1 expression in the kidney cancer, and is that, I actually ask you that, is that a reliable marker for the response rate of some immunotherapy? Or is there any report that follow such a PD-L1 expression after or during the treatment of immunotherapy?
As you mentioned, the PD-L1 expression in the tumor is a dynamic status. So if we treat the patient with the TKI or other treatment, the PD-L1 status is changing. So in the second line treatment of Nivo treatment, the PD-L1 expression was not good prognostic marker. But in the first line treatment, PD-L1 is maybe a reliable biomarker with the response with the PD-L1 targeted agent. In the atezolizumab treatment, with the combination treatment, if the PD-L1 expression is higher, the response is higher also. So probably it is good for really a good reliable biomarker to treatment.
Does anyone follow the PD-L1 expression during or after treatment?
Yeah. Also, someone measured the PD-L1 changing of the PD-L1 or other immune profile during treatment or after treatment. So the change of the immune response, some of the immune response factors are probably different candidates of the prognostic markers for the treatment of the immune checkpoint inhibitor.
Thank you. Is there any question or comment? Thank you very much. I'll toss the mic to Professor Chung for panel discussion.